Hello and welcome to today's special Gulf News webinar, PCOS and Pregnancy, How to Ensure a Positive Outcome, brought to you by Fakeeh University Hospital. Now, becoming a mother is one of the most exciting milestones in a woman's life, but for those with polycystic ovarian syndrome or PCOS, pregnancy can be elusive or present unforeseen complications. PCOS is a hormonal disorder common amongst women of reproductive age, with around 20 to 25% of women in the GCC suffering from the condition. Women who have PCOS often have trouble conceiving due to the high levels of male hormone androgen produced as a result of the disease, interfering with the process of ovulation. Concomitant features such as insulin resistance, impaired glucose tolerance, obesity, and excess weight can further complicate their journey to motherhood. Research shows that women with PCOS are 3 times more likely to have a miscarriage, and they are at risk of developing preeclampsia and gestational diabetes, as well as pregnancy-induced hypertension. With a larger baby, they might also experience a difficult delivery. However, despite these challenges, patients are in fact able to increase their chances of a healthy pregnancy and delivery. Whether you are pregnant or looking to start a family in the future with PCOS, this webinar will take you through everything you need to know. My name is Sally Musa, and I'm delighted to be joined by 3 leading health experts from the esteemed Fakeeh University Hospital. Dr. JC Janker, Specialist Obstetrician and Gynecologist. Dr. Ala Yunus Muhammad, also Specialist OBGYN. And we welcome back Dr. Ahmed Hassoun, Clinical Professor and Consultant Endocrinologist. Fakeeh University Hospital is built on an integrated healthcare model, bringing you the legacy of over 4 decades of compassionate care drawn from the renowned Fakeeh Care Group based in Saudi Arabia. It is also a world-class academic center committed to excellence through research, education, and clinical care. Located in Dubai's Silicon Oasis, Fakeeh University Hospital is a 350-bed state-of-the-art facility providing primary, secondary, and tertiary care. It is equipped with cutting-edge technology and smart systems, so you know you're in very good hands. Welcome to all of our esteemed doctors, and Dr. Ahmed, if I can start with you. What is polycystic ovarian syndrome and how common is it, particularly in the UAE?
First, thank you, Sally, for being with us today for this very important webinar, and thanks to my colleagues as well, our gynecologists who are joining us here. Thank for making this possible to educate the people who are with us, hopefully, about this important syndrome. Now, polycystic ovary is known to probably many of people, about what it is. Basically, it is a hormonal disorders affecting the woman, usually in the reproductive age group. Now, it is different how it's presenting. Sometimes it's present with irregularity of the cycles, associated with increased hair, facial hair, acne, and increased level of, as you mentioned earlier, male hormones, testosterone, and similar. So this is how it is. Now, the other part of it is the question of how common it is. Now, it is the most common female endocrine disease, hormonal disease that we are aware of. And basically, it's the most common, probably my colleagues can help in that, about infertility, probably the most common cause of infertility they will face in their practice. In addition to that, these people who have this disease depends on your definition. And again, this is sometimes you have differences in how you define it with regard to the diagnosis purposes. But generally, it's very common, actually. It's, between 8 to 20% in some studies. Again, as I said, it depends on the criteria we are using for diagnosis. And in UAE, for example, it is probably with the more common side, maybe 20 plus, as you mentioned earlier, I think in the Gulf. There is not much a clear prevalence study here, but there are some surveys done in UAE showing it's not a diagnostic, but it's more of describing some symptoms. And in some of the symptoms, it might reach 30% of young students, university students, female students between the age 18 to 25. So it is common. It is very common, actually.
Dr. JC, if I can come to you now, let's delve deeper into the signs and the symptoms, and in fact, what causes PCOS.
Good morning, Sally. Thank you for the invitation. PCOS, as you see, it's a syndrome, and the signs and symptoms might vary. You could get a child in her teens, then another patient could be in the reproductive age. Another could be into the late 30s, 35, 40. So the presentation, the diagnosis, and the treatment varies for all these three. For example, I could get a teenager or a child probably at 15 or 16 years. Here, what happens is that mainly the complaint could be absence of period, which is very common at this age. And mainly we use the next diagnosis, which is an ultrasound, which again, we could miss out in a young child, because to pick up polycystic ovaries in an ultrasound could be too early for a 14-year-old. So what I do for each of my patients is, depending on the age, that's how we have to deal with them. So for a young child, if the period misses, it could be common, but still we go in for an ultrasound. Even if you do not find the ovaries as polycystic, which is too early, ideal diagnosis is by blood analysis. So we could go for the hormone analysis, the testosterone, which is the most common hormone, along with the insulin, which is raised in this age group. Into the reproductive age group, most of them come to us, mainly it's fertility, because PCOS involves mainly 40% of the cases of fertility. And the most surprising feature is that there could be some of them who could be normally ovulating, even though by definition, we could tell that absence of period or reduced period. But we could have a certain group which are called as lean PCOS also. So here we start with the evaluation of fertility, and basically it's the ultrasound which gives us a picture. So of the criteria, Sally, we need at least 2 to be diagnosed for polycystic. Either it's a patient's complaint, which could be period, absent of period or reduced period. It could be the blood analysis, where we use 2 criteria, that is, we use the testosterone and the insulin. And the third is the ultrasound features. When we go into the ultrasound, now we get a lot of reports which is reported as polycystic. But if you look at the picture, this could be like a multicystic ovary also. So we should be very careful when we diagnose polycystic, because we need to have a minimum criteria where the ovarian volume should be more than 12. And we need to have follicles. That is, the eggs which are formed every month doesn't break out, and they collect in the ovary. And when we do an ultrasound, we see this typical picture of a polycyst, like a pearl, a necklace pattern. So it should be more than 12. So this is very important, because sometimes I get these ultrasound reports as polycystic and it doesn't really fit into the real polycystic picture. So I think these are the usual common signs and symptoms, and the rest what Dr. Ahmed told about hair, that could also be one of the features. So it could be periods. When you have hormonal imbalance in the blood because of testosterone, they could come to us with excess facial hair or hair loss or acne, and then the ultrasound. So I think these are the most common signs and symptoms, and weight gain, of course. Weight gain is also, so it's a clubbing of all that. So when a patient comes, we need to look into all these things put together to diagnose polycystic.
Okay, that's very interesting. Can it also go the other way? You were talking about a lack of periods. Can it go the other way, where you get extremely heavy and prolonged periods as well?
Always extreme heavy, it's usually followed by absent period. So sometimes what happens, the hormone works on your uterus for probably 2 to 3 months without period. And then when it comes, it doesn't have the mechanism to stop, because as we know, this is something to do with the hormone. It's basically a hormonal imbalance. So they could come with absent period for 2 to 3 months, and then later on with a heavy period, which would not stop without medication.
So it's definitely marked by that irregularity. Dr. Ala, if I can come to you and ask you about the way that it affects a woman's ability to conceive, because a lot of women, they usually come to know that they actually have PCOS when they have trouble trying to get pregnant. So can you go into a bit more detail about how it does affect a woman's ability to conceive?
PCOS is a wide range of disorder. It can affect the fertility because of anovulation. The woman can have 3 or 4 cycles in a year. This anovulatory cycles and lack of ovulation can affect the fertility. So how we can treat these women if they came only for fertility issue and we have diagnosed PCOS, it will be treated according to their symptomatology. Some women, they can have a regular period, but still they cannot conceive. Some women, they can have irregular period. They will have irregular period in the sense of every 3 to 4 months, and still they cannot conceive. Then we will look at the polycystic ovary as a complete syndrome, the same like my colleague, they emphasize. Polycystic ovary is mainly an insulin resistance, so it will be associated with other symptoms: obesity, increased body mass index, there is hirsutism, there is irregular period. We started first with lifestyle modification. The most important is lifestyle modification. We have to tell the patient a part of the medicine. The medicine, leave it alone, and our medicine is what you will gonna do to your life. Lifestyle modification, we encourage exercise regularly. If she is not doing regular exercise, we encourage her to start slowly, 3 times a week, and then increase it to 5 times, and then every day for 30 to 45 minutes of exercise, eating a healthy diet, regular healthy meals, especially emphasizing on a breakfast, and then minimizing insulin resistance. If she is obese and she had not obesity, we have to categorize the patient: increased body mass index, overweight, then obesity, then morbid obesity. If it is only overweight, then the lifestyle modification can help her a lot with reducing her body weight and will recover her ovulation on a regular basis. And then if she is obese, we need definitely to prescribe for her insulin sensitizing agent. Although metformin is not licensed by FDA for polycystic ovary, but we use it on a regular basis for patients with polycystic ovary because it is an insulin sensitizing agent and it can reduce her insulin resistance and restore her ovulation. By restoring the ovulation and increasing insulin resistance, she can get pregnant. So the first of all is modification of lifestyle, which is the most important part of polycystic ovary disease. And definitely, when I sit with the woman, I will tell her about the pathology, explain for her that this is not something that we will treat it for 6 months, 1 year, 2 years. It is a lifelong disorder, and she will have it since she got it from the teenager, and then she will have it throughout her fertility till she will have the postmenopausal, and then there's no more polycystic ovary. The long-term effect of polycystic ovary is something that we should emphasize on it, because the long-term effect started from the ages of 20 and 30. Encourage the woman to have an ideal body weight, avoid obesity. By avoiding obesity and avoiding overweight, we will reduce the risk of gestational diabetes, reducing the risk of hyperlipidemia, reducing the risk of hypertension. Mostly, how to assess the woman from the beginning is to treat her symptoms, what she came for. Is she coming because of the fertility problem? Then we have to look all this factor and treat the fertility problem stepwise. Because if she is, suppose she is coming with a body mass index of 32 or 35, and she had irregular period. The most important now to reduce her weight, because she cannot get pregnant with such a weight. This weight by itself can increase the risk of miscarriage during the pregnancy, increase the risk of gestational diabetes during the pregnancy, increase the risk that you already mentioned, risk of hypertension, preeclampsia, gestational diabetes, miscarriage. So first of all, let her reduce her weight, start the pregnancy, at least not with the ideal weight, but with the overweight range, at least with the overweight range. By reduction of the weight, she can have a regular period, even without insulin sensitizing. Once she started the lifestyle modification, exercise by itself, exercise and healthy diet can make her ovulate without ovulation induction. If after a trial of 3 months, we have to give a time. We cannot, it is not a matter of 1 month, 2 months, 3. At least give her a 3 months time to reduce her weight, change her lifestyle model, and then prescribe metformin. After that, if she felt still the period is irregular, then we will use the medication to regulate her period and to induce ovulation. Induction of ovulation, we start usually with simple methods, and then if it didn't work after 6 months, we'll go for more complicated and hormone-inducing methods.
That's incredibly comprehensive, but I think we will get into more of what can be done if those measures do not work. But I love the point that you did make, Dr. Alat, that this really is it is a lifelong condition for a woman who does have it. And I'm going to come back to that point in just a moment. But before we do continue, I just want to mention a couple of housekeeping points for our audience here today. If you want to ask any of our doctors a question during the webinar, please do type it in for us by clicking on the questions tab. It's at the bottom of your screen. And if you do want more information on the panelists or Fakeeh University Hospital, you can click on the buttons to the top left of the screen that say speakers and booths. Right click on that and you can open a new tab there, and you will still have the webinar running and open and listen to that at the same time. So finally, we do have a poll that is running. We love to do this in every webinar where we get to ask you questions so that we can get a feel for your thoughts on today's topic. And the first question for the audience is this: is PCOS the most common cause of fertility in women? Do you think it is or not? Then you can click on yes or no, and then we'll have a look and see where everyone is on that. And so with that, I want to come back to you, Dr. Ahmed, in terms of how PCOS is actually diagnosed and at what age, because, as, Dr. Ala and Dr. JC said, very much it could be in the teenage years, it could be, in the 20s, in the 30s, and so on. I know for me, I actually suffered through years of extremely heavy periods and misdiagnosis. It took a long time for doctors to actually be able to diagnose it as polycystic ovarian syndrome. So what's the best way to diagnose it?
Thank you, Sally, again. Basically, there is no single test that will diagnose PCOS. That's to make it clear. It really depends on the presentation, the symptoms of the patient, as we talked earlier, irregularity of period, heavy period, as you mentioned, infrequent periods. This is from a gynecological point of view. The androgen, increased hormone, male hormones, the hair, the acne. So these are the symptoms are there. And basically, most of the people agreed on the societies, the international society, about the diagnosis, is that you need two things to diagnose from three important things. The first one, the cycle irregularity with anovulation. The second one is symptoms and signs of androgen, which is the male hormone excess, whether it is biochemically in the blood test or it is by the signs and the symptoms of the patient. And the other one, the third one, so two of these two. The third one is the morphology of the ovaries by doing the ultrasound, as my colleague Dr. JC said earlier. And this is very important what she said. It's really have to have the correct diagnostic criteria by the morphology. It's very important because, as she said, many people will say polycystic and it really does not fulfill. And there is an agreement on how to do that. Now, one other point I think Dr. JC mentioned about the young people, the adolescent. I think it's very important to remember that to diagnose an adolescent soon after menstruation is not really, agreed by everybody, because we know, all of us, that in the first probably 2 years, starting the menstruation in an adolescent, in a puberty time, you will have irregularity anyway. So that will not settle even in a normal person who does not have PCOS. So we usually delay this probably 2 years, after 2 years at least, then to diagnose if the symptoms continue to be there. Now, if there is excessive symptoms, for example, excessive androgen, male hormone signs and symptoms of the patient, we can still say, well, she has high risk for PCOS, and then we will follow and then confirm the diagnosis later. So that's how we do it. And we need to be very careful on, for example, in adolescent young people, as I think Dr. JC mentioned, that the morphology of the ovaries in young girls is different than in the adult. And using the criteria of the size, you have to be very careful about the size, how many cysts there, because in young girls, you will have anyway more cysts, in the ovaries. So it's very important. Actually, it's recommended not to use the morphology, which is the ultrasound figure in adolescent. It to be used in the adult more than in the adolescent.
Dr. JC, I want to ask you, is this something that is hereditary? If I have it, can I give it to my daughter? Looking at the cases that do need medication and treatments, Dr. Ala alluded to some of those, but if you can elaborate on some of those too.
Treatment-wise, yes, genetics, because basically now this was eluding. Even the biochemistry, everything was confusing for the past years, Because just from 1990s, we got to know about this polycystic. At that time, we used to wait for a case to just see how the ovaries were. It was very rare. Now in the clinic, in a day, we pass by, you get at least 5 to 6 patients every day. So diagnosis has become very easy, but the treatment part has become a little motivating because it starts with the patient, because basically this has got a genetic feature to it, starts with a very young age. The transition is from a teenager. So when I see a patient at 25, already the changes have already happened. So the patient needs to understand when we diagnose polycystic, it has got a lot to do with the underlying metabolism, the hormonal changes, which would not be changed within the next 2 to 3 months. So magic doesn't work fast. So people look into medication. So medication is just a pathway to reach there. So first the patient needs to look into long-term plans, not short-term plans. So first we start with lifestyle. When a patient comes to my clinic, the first thing I ask, but I look at them, I look into the body mass index. So if they are into the body mass index more than 30, then we advise them on the lifestyle change first. Because everyone now is very much aware of the medication, because glucophage, the insulin sensitizer, is being freely used. So even if it's a child, say a teenager, 18 years, I get patients, 24 years, been on glucophage since the age of 20. So it doesn't work like that, So initially, we look at the patient, so it's a complaint we look into. So is there any irregularity of a period? So we need to address each complaint. Is the irregularity? Is it the hormone issue related to the face? Or is it acne? So if it is acne, her issue, you do not need to have, because people confuse polycystic ovarian syndrome and polycystic ovaries, even though both are the same. You needn't need to have polycystic ovaries to have the syndrome. You understand my point? There are different types of polycystic. Ideally, there's about 5 types of polycystic, basically. Some have just the hormonal imbalance. Some do not have the hormonal imbalance. Some do not even have the ovaries showing polycystic. So I might do an ultrasound, there's no polycystic, then I have to work up the hormone. So we have to deal with what the patient's issue is. So if it's a period, that's the medication for that. If it's a hormone, that's the medication. If it is something like fertility the patient looks into, then we need to focus on that. But everything starts with lifestyle modification. And to make the patient aware, like Dr. Ala said, it's a long-term change, because now ideally the patient needs to be made aware that polycystic ovary is a part of a metabolic syndrome. So we are dealing with something more than the ovaries and the hormone. We are looking into more into the heart, more into the long-term changes as developing diabetes later on. So if you start earlier on, then I think the whole journey goes well. But it requires a team, and the patient needs to be motivated, and the family support. All these things work. So medication is as per the requirement of each patient. For example, if I get a patient who has a period, she gets it once in 2 months. Ideally, we would tell the patient that's okay, because as per our criteria, the patient needs to get just a minimum of 3 periods in a year. That is, she can be without a period for 4 months. More than 4 months, we advise them to have a period, because sometimes the hormone works on the uterus, giving rise to a condition called endometrial hyperplasia, where the lining becomes thicker, and through the years, it can cause a lot of changes later on in life, or she could have a heavy period and all that. So it doesn't mean that you need to have a period every month, because sometimes it becomes distressing for the patient, because polycystic, years back, any polycystic patient comes to us, every 2 months, we do the pregnancy test, then we give them a medication for the period if she's married. And last, it becomes frustrating. So now the idea behind this is you just need to have a period once in 4 months, so that at least you're ovulating and your hormone doesn't stay back into your uterus.
It's so important to look at every single case. And I know that this is an incredible webinar, but, at the end of the day, each case, as you said, is different. There's, 5 different types when you're talking about polycystic ovaries. But Dr. Ala, coming back to you and the point that you certainly made very well and very clearly, and that is, lifestyle, losing weight. I know that when I wanted to get pregnant, I think we were trying for about a year, and I had PCOS, and it took losing 25 kilos, and then I got pregnant and everything was fine. It's incredible how important that is as a risk factor, for all of the other different things that we talk about with PCOS, and particularly when we talk about starting a family. So when a woman does come to you, Dr. Ala, and she wants to start a family, she wants to get pregnant, what should her approach be, beyond lifestyle and losing weight? And when do you have the reproductive technologies coming into play?
The approach, first, we have to assess whether she is simply like a preconception counseling. We have to assess her risk of conception, the age of the patient, the fertility profile, whether she got pregnant or not, any previous diseases, any gestational, any previous insulin diabetes, any insulin problem, obesity, infection before, and then the regularity of the period. It's not only for obese women to normalize their body mass index, it's also for lean patient with polycystic ovary. The lifestyle and exercise is very important issue. Then if she didn't conceive, suppose that she did all these changes and we give a child of 6 months and we give her metformin, we give her to regulate the cycle, she did her job of lifestyle modification. Then we can start with ovulation induction. There's many drugs. The oldest drugs in the market is clomiphene citrate. Have been used more than 50 years ago. Clomiphene citrate can induce ovulation. It's originally an anti-estrogen, but still it can induce ovulation, and we can prescribe. Although there is a side effect of the clomiphene citrate, there is a drawback. There is more drugs in the market that is better than clomiphene citrate, but more expensive. Example, letrozole, and we can try up to 6 months. After 6 months, if she didn't conceive on ovulation induction, then we will go for IVF, a productive technology, and inducing the cycle with more sophisticated hormones, which is injections starting from the first day of the cycle with FSH and LH. But at least we have to give a trial of first with clomiphene citrate or letrozole, and then we will go for IVF. IVF, there is now a lot of technologies available, and there's a lot of advance in ART, assisted reproductive technology, in the market. But our job is to advise when we start, we will refer for IVF. It's not all the time immediately we will go for IVF, depending on the woman's profile. Suppose I have a woman who's 39 years. She haven't been pregnant before. She's trying for the last 4 years, and she's a known case of. She had taken ovulation induction with sometimes letrozole. Shall I continue ovulation induction with letrozole or clomiphene? No. 39 years, the time is running. We cannot delay her because her fertility is getting on the lower side, and she haven't had pregnant before. So we will refer her directly for assisted reproductive technology for IVF. There was one question that you had asked Dr. Jayasi, and I would like to comment on it.
Please.
Whether it is a genetic, whether I will give this syndrome to my daughter. Yes. The latest research, it mentioned that it can run in the family and the mother can give it to. It is something, a mutation in one of the genes that it makes the woman more susceptible to get polycystic ovary. That's why when we speak to the woman, I don't like her to get upset from her look or from the symptoms. This is something you should not be ashamed of it. This is something from God. You have certain mutation in your genes, not something you have done it wrong. Something we can work on it, and we can improve the profile of the woman. The psychological aspect of the woman is very important. In polycystic ovary disease, most of the women, they might have an anxiety problem, they might have depression. Screening for depression and anxiety is very important when we meet every woman with polycystic ovary disease.
Wow, that's one that I didn't kind of think about, anxiety and depression and the link actually between them and PCOS.
Yes, because of sometimes of the figure of the woman, because sometimes she faces a problem with losing weight. She is doing her best, but she cannot lose the weight. She's doing her best, but there is a hair, abnormal hair growth on the face. There's thinning of her hair, which is affect her self-esteem, affect how she see herself. This we should discuss it with the woman. This we should point by point. We will do it. Hirsutism, we should treat hirsutism. Thinning of the hair, we can do something for the thinning of the hair. But all it is related to insulin sensitivity, and the main issue is to reduce the androgen level.
This is it's a big one, and thank you for bringing that up, because it really can get to you. It can get to your confidence. It can get to your ability to be motivated to lose it. It's really hard. It's the hardest thing, to do that, particularly when, if you have PCOS, you're more likely to put on weight. And, it's kind of like a vicious cycle almost that happens there. So we'll get to more into that. But I want to come to the poll and have a look at everybody who's voting. Thank you for everybody who's jumping in there and voting on the polls for the answers. Is PCOS the most common cause of infertility in women? Yes, the answer is yes from 77% of the respondents. 23 say no, and so you would be right there. And I'm loving the discussion that we are having with our doctors here today. Dr. Ahmed, if I can come back to you and ask you about that. When we're talking about the insulin resistance and the role that can play there. If they are insulin resistant, can that affect treatment then?
Thank you, Sally. We're talking almost in the same things, and we are enforcing each other's opinion, which is good. Basically, the issue of resistance is important. But again, as mentioned earlier, the hereditary factor is very, very important. So we have two things. We have something hereditary, we call it like predisposing for the PCOS, and then we have what we call like environmental, factor that we can hopefully control some of it. And together we'll develop, PCOS. So for the genetic factors, we cannot change, as you know, we cannot change our parents. And just to make it, exciting, I just learned recently from my readings about there is even not only the female, mother, even the father who have also, metabolic syndrome, which is like insulin resistance, can be a hereditary factor for the girl who will have PCOS. Very interesting. In addition to the mother who have PCOS herself, and the one who have even morphology, the PCOS ovaries without the complete picture, this is also genetically, can be affecting the child. And the exposure of androgens to the mother is important. One thing important always we in our field we like to emphasize on is the fetal life. The fetus, while in the development time during the pregnancy, it is very important that we have the weight of the child is progressing with an acceptable range, not too much and not too little. In addition to other metabolic effects, but it has been shown that people who have low weight, fetal getting low weight or high weight than the normal, are having more chances to develop PCOS as well. Coming back to the main issue now, to the insulin resistance, which is very important. This is an environmental factor. And actually, some of the women who have PCOS predisposition, they will not show the syndrome until they gain weight. And they gain weight, when they gain weight means they gain, the issue of insulin resistance and the metabolic syndrome picture. So some people, even if they have the genetic, if they really keep their weight, healthy weight, they might not show the picture of polycystic ovary. So polycystic. So insulin resistance is very important. Hoping that we can prevent it from happening. Hoping by having a healthy weight from the time we know, adulthood, and even actually before, as you said, during the fetal life, we should probably think from that time to keep a healthy weight for the fetus and the baby and so forth. Going back I think you asked about the insulin resistance role. So the insulin resistance mentioned earlier by my colleagues also, that this is important. This is what we can do with regard of the environmental factor. So a person gained weight, we can work into, first of all, it's better to prevent it from happening, as we mentioned earlier. But if somebody gained weight and developed the picture, the complete syndrome, then they have to really think, as mentioned very clearly by my colleagues, to start doing weight reduction. And the weight reduction not only by exercise, actually by the diet. The diet is very important. Actually, from our knowledge about the field, that weight reduction is mainly affected by the diet and supported by the exercises. We say that about 70 to 80% of the weight reduction is accomplished through the diet, and the 20 to 30% remaining is helped by the exercise. So both of them are important, but you cannot lose weight and reverse the process without getting the diet, work on the diet. And we can talk about the diet if you want to.
Yes.
If you have it.
We're definitely going to get into that later. But that's a really big point. And anybody who's a trainer will tell you, when they work with those who do want to lose weight, people think, I can, do some running or high impact exercise and I can keep eating the way I'm eating and very little changes. Surprise, surprise. We're going to get into our second poll now. And the question is, does PCOS increase the risk of complications during pregnancy? Once again, jump into the polls, give us your answers, yes or no. We've got some people already voting there. And Dr. JC is going to give us a bit more insight into that topic. Dr. JC, we do talk about the way that PCOS increases the risk of complications during pregnancy, but what are these complications and how can they be managed?
So when we start with PCOS and pregnancy, most of them, about 30% conceive naturally, but some of them, most of them, the rest, when they come in for pregnancy, already they have completed some kind of a treatment. either, as Dr. Ella mentioned, ovulation induction medication or other intrauterine insemination or IVF procedures. So already they're into following a period of fertility. They've come to us, not after the natural conception sometimes. So that itself is a stress for them because they come into you after having a treatment for fertility. So these are infertile couples having treatment, conceiving. So the stress levels are more for them. And when you look into the hormones, as you know, polycystic ovary is linked to insulin resistance, so the quality of the egg. So in the first trimester, we find that miscarriage risk is slightly higher when patients conceive and if the insulin resistance is not corrected. So that's one thing in the trimester 1, which we see. Then when we move on into the second trimester, as the baby's growth progresses, there is increased tendency for women with polycystic ovary to develop diabetes, gestational diabetes in pregnancy. Along with that, as we know, polycystic ovary is part of a metabolic syndrome, increased risk of developing high blood pressure and the risk associated with that. Now, when you tell about gestational diabetes, what we look into is diabetes developing only after the 5th month of pregnancy. This inversely affects the baby because it increases the carbs, or it's something to do with the insulin in the body. And we find that the weight of the baby can increase. At the same time, sometimes because nowadays we find all these things early. We have screening for diabetes, we have screening in pregnancy, we do routine checkups. So we have prevented the long-term complications. Like years back, we used to find the water levels rising. So nowadays, I think we have moved on from that kind of obstetrics because we have all these technology now to find these. Otherwise, we find the baby weight. That is the most biggest thing which we are facing nowadays. The baby weight increases, because of which we find that cesarean rates are rising. So when a patient comes with polycystic ovary, in the first day, start with dietary changes, advising them on to start with a low-carb diet earlier on. And these patients might require certain supplements because, as we know, the hormone called progesterone is slightly low for these patients. So it is advised to supplement them to protect them against this luteal phase defect. So this is something that the patient might require for the first 4 months sometimes. This again varies, Sally, with each patient, because I've had some of the patients, I have 3 patients, which I can mention in the last year, coming to me, never knew they were pregnant in the 4th month. And 2 came in the 5th month. She didn't even know she was pregnant. So I told them, you are lucky polycystic patients because we didn't pump you with those hormones. But then it's always better to diagnose it earlier. So we worry about miscarriage risk. We worry about gestational diabetes. And with gestational diabetes comes bigger babies, bigger risk for C-section. And even with these bigger babies during labor, we could find that labor gets prolonged and we could have labor complications like, in a bigger baby when we deliver, it could be very difficult to deliver because of the shoulder, something called a shoulder dystocia. So because of this, we screen these patients earlier. You would be, most of the women is aware of this glucose test, which we do in pregnancy. So we diagnose it early, we screen the patient early so that they are sent to have a dietary advice. So it's basically more into prevention where we can prevent these complications, I think.
There's a lot to think about there. I would love, Dr. Ala, if you have anything to add there in terms of, how you do manage those complications that can arise for women during pregnancy who have PCOS.
Yeah, for patient who is polycystic ovary disease and who were on metformin before they get pregnant, it is advisable to continue on metformin during the pregnancy because metformin, it can increase the success of the pregnancy and reduce the risk of miscarriage, especially in the first trimester. Those patients who were conceived while on metformin, they are liable to get gestational diabetes. About 1 to 2 of women out of 10 can have gestational diabetes. So we recommend from early pregnancy, even from first trimester, to screen for gestational diabetes. We are a little bit earlier than the usual recommendation for other ladies who get pregnant naturally without polycystic ovary disease, where we recommend to do oral GTT later in a pregnancy in the second trimester. But for those who is polycystic ovary and they were on metformin, they are more liable to get gestational diabetes. So we need screening with glucose tolerance test 2 hours early in a pregnancy from the first trimester. Multidisciplinary team approach and liaison with our endocrinologist is very important point to manage those patients who is on metformin and who had developed gestational diabetes during the pregnancy. As I mentioned before, they have a risk of developing hypertension, and so we can start them with low dose of aspirin from 12 weeks onward to the rest of the pregnancy. If they are overweight and have conceived while they are taking metformin, the folic acid dose will be not like the other population. It will be more increased because they have overweight, obesity, plus gestational diabetes. So the folic acid dose will be 5 milligram rather than 400 microgram. These are the main recommendations, but always we individualize the care according to the woman. Every woman is different from other women, even if we take 2 polycystic ovary disease, 2 women who conceived while on metformin. Every woman characteristic, every woman is different, and we have to make a plan from the first pregnancy, from the time of conception, 5 weeks, 6 weeks, we make a plan to the end of the pregnancy. But these are the recommendations, like the outline to continue on metformin, to screen for gestational diabetes early in a pregnancy, increase the dose of folic acid, and aspirin if she had a history of gestational hypertension in a previous pregnancy. If she is on a borderline, then aspirin, low dose of aspirin. Now the recommendation, even 150 milligram of aspirin at 12 weeks onward to the whole pregnancy. Not even before it was 75 or 82, sometimes 100 milligram. But now the recommendation is 150 milligram of aspirin from 12 weeks onward. And liaison with our endocrinologist is the most important. We are lucky to have Dr. Ahmed here with us as a team.
Absolutely. And I think that's really important to highlight that, you know, for a woman who is pregnant with PCOS, there's a holistic approach that is really necessary here to make sure that the complications are mitigated as well. And just very quickly, I'm wondering, you know, in terms of premature delivery, that is quite common. And is it quite common? And is there something to be done about that?
Yeah, a premature delivery, if she had gestational diabetes with a big baby and the growth of the baby is more than the normal growth percentile, more than the 95 percentile, they are liable to get premature delivery, premature rupture of a membrane, and this can affect the outcome of a pregnancy. So the main issue is to control her diabetes. Sometimes we need more than metformin to control her gestational diabetes. Sometimes we need insulin in addition to control the growth of the baby. If we have a big baby, of course, we will have complication and we will have a premature delivery. In addition to the liability of a patient who have gestational diabetes to have infection in the vagina. Gardnerella vaginosis is one of the common reasons to have a premature rupture of the membrane and preterm deliveries. So treating of infection, treating of candidal infection, starting from the early in a pregnancy, screening for any infection during the pregnancy is very important. We will not neglect any even simple complaint of any patient, especially a pregnant lady. Even if she had a very mild discharge, you have to look at the discharge, see what is it. Is it candida? You have to treat. Is it Gardnerella vaginosis? You have to treat, because this is a cause of even first trimester miscarriage, premature deliveries. Yeah.
Very important. Yes. Thank you so much for that. We're going to jump in and have a look at the results of the second poll. Does PCOS increase the risk of complications during pregnancy? And our audience is really on this one. Yes, definitely for that one. Yes. 85% are saying yes. And I think we're getting some outstanding information here about how, in fact, it can do that and what can be done about it. There is another question. This will, in fact, be the last question for our polls today. And it is, can lifestyle changes help with managing PCOS? You probably already know the answer to this one, yes or no. And Dr. Ahmed is going to enlighten us a little bit more about that. You know, we've talked about diet, we have talked about exercise, the importance of that to treat PCOS. Can you actually reverse it, Dr. Ahmed, without medication? And, you know, some people even talk about there are certain foods that you should have, that you shouldn't have, you know, a bit more specific kind of advice when it comes to, you know, as you said, the importance of diet and what should be consumed and what should be avoided.
Right. Thank you, Sally, for the question. I will say, as a management treating of PCOS, you can. To reverse it completely, you cannot, because, as I said earlier, there is the genetic factors. You cannot change them. So you can not reverse it, but you can manage it and make it very, you know, controllable, very easy to live with, but you cannot reverse it, basically. Now, with regard of the treatment, I think we already discussed very nicely about the lifestyle, right? Already emphasized before that clearly there is evidence that weight loss, you know, with diet and exercise, 5 to 10%, have been shown very significantly beneficial to the ladies with the PCOS, especially for getting ovulation and having better chance to get, you know, pregnant. Now, doing that naturally, again, really to emphasize on the diet. Now, any certain diet, well, there are many diets you can use. Some people use low carbohydrate diet. Some people use keto diet, not necessarily all their life, but temporarily to induce some of the reduction of the weight. Some people use just a low-calorie diet. So whatever is feasible for the person to achieve the goal, I recommend doing it, whether it is a low-calorie, whether it is keto diet, or if it is low-carbohydrate. The main one I use usually for my patient is low-carbohydrate diet because, Sally, you know, and my colleagues knows that our diet is really, you know, full of carbohydrates. And we have noticed that the carbohydrate is the main factor of our obesity in the world, not only in our region, but all over the world. And that is also reflected on diabetes, you know, prevalence as well. Now, you mentioned something about any specific thing in the diet. Really, I would say the carbohydrate, as we said, we reduce it. That's my favorite thing to do. But for some supplementation, there is a lot of talk of some supplements. Some people coming to us asking us about something to use like a supplement or nutritional supplement. There is some evidence of some of them, but we need to be very careful. For example, inositol is one of the supplements that is available, but we need to be very careful and you have to discuss it with your doctors, you know, our gynecologists or us or the patient doctor themselves to choose the right one because there is many things in the market that might not be the correct one to use. So I wouldn't recommend to use anything like that without discussing it with their physician. The second thing is about, for example, omega-3. Now, omega-3, again, is available in the food that we have. Many of the food, we can find omega-3 in it. And we usually recommend naturally omega-3. But even if you're going to take omega-3 from, you know, as a supplement, again, you need to be careful about so many things, you know, over the counter of omega-3. Again, it's better always to discuss this. But there's some evidence that both of them, inositol and omega-3, can help in the metabolic benefit and insulin resistance reduction.
That is really important to think about, you know, those things. Of course, you can get the omega-3, you know, in things like fish and other whole foods as well. But, you know, it's vital that we kind of look at our lifestyle. Where can we, you know, and when you said carbohydrates, it makes me cry every single time. You know, you and I are both Iraqi. We can't live without rice. You know how it is. And I know that Dr. JC agrees as well. It's just, it's one of the joys of life, but you gotta reduce the portions, unfortunately, right?
Yeah, I think the portion is enough, Sally, just the portion, because it is really overwhelming that we have carbohydrates in our diet. So not saying low carb, I would say lower carb. That's why usually I
Right.
note a lower carb, because I know the carb in the food is high. Okay,
Yeah.
so lower carb.
Yeah, very important. Dr. JC, if I can come back to you on this one, can women with PCOS have a normal delivery? Is there a higher percentage of women who end up getting a C-section, in fact?
Women with polycystic ovary means who develop gestational diabetes have a higher chance of cesarean rates because if it is not uncontrolled. So, in case the patient is well aware and we have a team, as Dr. Allah said, we have Dr. Ahmed with us. So, with a very good glycemic control, if we can control the baby weight, the mother is very much aware. Ideally, we are supposed to leave the patient with well control up to the week 40. But in case and we find out that baby is growing bigger than the fourth percentile, then we can induce the patient. And this increases the chance of a normal delivery and reduces the risk of complications like, shoulder dystocia and all that. So everything looks into prevention, early diagnosis, early detection, screening. So it's a journey for the patient and for the doctor. So when a patient comes with polycystic ovary, we always think of gestational diabetes could be the next thing we should deal with. So screen the patient early, dietary advice, early detection, send to Dr. Hassoun, and then go for a normal delivery.
Yes. And Dr. Ala, if you can add to that, or, particularly there are those who say that water birthing, hypnobirthing, are these recommended birthing techniques for women with PCOS?
Well, same. If she is having normal glycemic control, not a big baby, we are not at risk of gestational. She doesn't have gestational diabetes. She started her own birth spontaneously. We didn't induce her because of big baby or because of gestational diabetes uncontrolled. Yes, this is an option to have a water birthing or hypnobirthing, because she is considered not at risk of baby could be in distress during labor. But if the woman had definitely a gestational diabetes, and she was, even if she is a glycemic controlled or she doesn't have hyperglycemia, and we have induced her at 38 weeks. We usually don't let the woman with gestational diabetes to go for 40 weeks. We induce them at 38 to 39 weeks. If she is completely under control and she doesn't want any induction of labor, we have to cancel her properly. Then induction of labor by itself, when gestational diabetes is there, then she is at high risk to develop fetal distress during labor, and she will need continuous monitoring during labor. Then water birthing is not advisable with continuous monitoring. But if she is completely normal, the baby is the normal size, very good glycemic control, she doesn't have gestational diabetes, she doesn't have hypertension, she is low risk woman, yes, definitely there is a place of water birthing.
Excellent. I love that. We've got a lot of people jumping in on the polls right now. Can lifestyle changes help with managing PCOS? It's an overwhelming 96% who say yes. And our doctors have given us a really wonderful, comprehensive answer to that one as well. But there are more questions that are coming in from our audience. So let's get to those. This one from Farida says, hello, how do you have PCOS and hyperthyroidism? Can they impact each other and affect pregnancy? And can you conceive naturally without IVF? Would a laparoscopy help? This is a question from Farida. Dr. JC, if I can give that to you.
I go through the points once more. Can you conceive? 30% of the women can conceive without treatment of polycystic. Like I told you, Sally, I've had patients come in 4th month, 5th month pregnancy. So yeah, that's the first thing they need to believe, that they can conceive, because they read all this and then it goes into your mind that, you cannot conceive, you cannot. So women with polycystic have this thing in their mind when they come, that they cannot conceive. Everyone can conceive, but we need to look into how much of metabolic imbalance is there. So you could be a person with normal, maybe a little irregular period, not much of a hormonal imbalance. Then you just need a little correction, maybe with a little insulin sensitizer, and you might even get into to have your normal period. Otherwise, what was the second one, Sally? You said
What about hypothyroidism and PCOS?
I think Dr. Ahmed would be the best person, because usually it's not hyperthyroid. We usually find hypothyroid linked with it.
Yes, that's what they've got, hypothyroidism. Dr. Ahmed, can they interrupt in a way that will affect the pregnancy?
I think in a separate way, yes. Each one of them have an effect on the pregnancy. As mentioned by Daisy, the PCOS, we talked about it, but hypothyroid is very important. And actually, most of our colleagues, when they look into our patients who are planning for a pregnancy, one of the most important tests to do is a thyroid evaluation, specifically for both hypo or hyper, but hypothyroidism is the most common one and the most important one to deal with it. And this is very important because it has to be sent to our, expertise, like people in the endocrine field and also our gynecologists who are really interested in this, to look into very fine tuning of the thyroid function, for example, the TSH level, what it should be, and like that. So it needs an expert opinion to be dealt with before even getting into pregnancy. But to affect it, PCOS, it's not directly affecting each other.
Okay, very good. Dr. Ala, there is Divya asking about advice for someone who does have PCOS but is not overweight, and insulin resistance is at the borderline, and she is trying to conceive naturally.
So, she is not overweight. Does she have a regular cycle?
That would be a good question to ask. Yeah, she hasn't outlined that, whether she does or not, but that's definitely a good question. Yep.
Yeah, if she had a regular cycle, yes. She is not overweight. She had a regular cycle. She can conceive naturally. But if she failed to conceive naturally, we can start with letrozole, ovulation induction, and we can have a trial of 3 months. It's all depending on the woman. What is her wishes? Whether to conceive completely naturally, because we are facing with a woman that she doesn't want any medication. She wants every natural things can be done for her.
Yep. Okay. Wonderful. We have some questions that are coming in that have been answered in the discussion. One from Needy, who says, I get my periods with a 3-month gap, and when I do get them, I bleed for almost a month. Is that normal? Dr. JC, I believe you covered that briefly as well, to say that, yes, there can be gaps like this as well.
Yes, Sally, you can have gaps, but sometimes, it's advisable to look into other causes, like she should get an ultrasound done. Is it polycystic ovary? Does she have anything associated? There could be an added thing like a fibroid, adenomyosis. So that's also important, because when we look into bleeding, we need to rule out other things associated. And sometimes I tell my patients, even though we advise them it's okay to wait up to 4 months, I sometimes get my patients who bleed heavy after, missing 2 months or 3 months. For them, I advise them to have a period after every 2 months, because sometimes the hormone is not the same for all of us. So it depends on each patient. Sometimes they come to us even after 4 months, when we stimulate them to have the bleeding, it's just minimal. So in case this particular person gets a heavy period after 2 months, the best thing to do is to evaluate for other conditions in the uterus. And then it's better for her to have a withdrawal, take a medication to have a period once in 2 months. Don't wait for the 3 or 4 month criteria.
Okay, excellent. If I can ask this question to Dr. Ahmed, what other reason could there be for infertility for a woman with lean PCOS diagnosed by 37 to 42 day long periods, enlarged ovaries, multiple follicles, but normal blood work and insulin levels, and responded well with ovulation induction medicines. Male factor is normal as well. That is from Kieran. I wonder if you can help with that question, or whether it's Dr. Ala.
Well, from our side, I mean, if the male factor, which is probably in my specialty, would be is normal, there's nothing I could do for the male factor. So we'll move to the female factors now. To, as you said, Dr. Ala.
Dr. Ala, yes.
Yeah, this case scenario, like she is regular cycle, she is PCOS, her blood test workout is normal, minimal insulin resistance, she could not conceive. We should look on other causes of infertility. Tubal factor is one of the causes of infertility. Look at if there is any tubal blockage. We look at the male factor, of course, when we refer the couple to the urologist, the male couple to the urologist for seminal fluid analysis. And if all this is normal, like normal seminal fluid analysis, no tubal factor, and ovulation, there is ovulation and we have induced ovulation, but still it didn't work, then we go for the category of idiopathic. Sometimes we cannot find the cause of infertility. We search for a cause, but we cannot find it. And in 10% of the couples, there is idiopathic infertility. And those couples, we refer them to ART for IVF, because we cannot find a cause of infertility. So always we can find a cause, and it is not always we should blame ourselves that there is a polycystic ovary, and that's why we cannot conceive. This is a very important psychological aspect when we treat couples with infertility. We don't blame ourselves.
Very important there. Dr. Ahmed, if I can come back to you, because you did mention, that there are questions coming through about the correct lifestyle modifications in terms of diet and exercise, because people, we will go on the internet and we will search for these things, the right diet to lose weight, PCOS, and sometimes there can be conflicting information. It gets very confusing. But you do say that, each patient should look at the diet that is going to best suit them. So do you have further advice on that?
As I mentioned earlier, my really best approach myself, I find from my experience, is to advise on lower carb diet, basically. Right. A lot of success with that, actually, we have seen. When you talk about lower calorie diet, although at the end, if they are persistent into doing this and adhering to it, whatever they do, they will be successful. The problem is to adhere to a low calorie is much difficult than to adhere to a lower, again, not low carb, lower carb diet would be much, much easier to adhere to. At the end, whatever you do, you will reach to the weight loss if you really adhere to what you really prefer to do. So I would say, choose the diet that you can do it. And many patients come to me here and I talk to them about some example, about some successful keto diet, some successful low-calorie diet. Most of them really will agree to go to a lower carb because they know their diet is really high in carb. So the most diet that I recommend is a lower carb diet.
Yeah. And I think it's really important to say as well, this is a condition that's not going to go away. Yeah. In a month, 2 months, 3 months, or ever really. So you do have to find something for you that is sustainable, and as someone who has had to lose weight, a lot of weight all at once, repeatedly, that is really the key. And you kind of almost have to experiment and start small as well. And don't kind of just go all in all at once. Start small and increase it in terms of, how healthy you can get and lower the carbs even more. And, and see what works for you. It's really not a one size fits all, is it? Dr. Ala, we have a very specific question for you. What is para-ovarian cysts? What is that? And is that common in women with PCOS? And does it affect pregnancy?
No, para-ovarian cyst, during the development of the genital tract in the woman, there is Mullerian tract that it is developed, and from that Mullerian tract it develops the uterus and the fallopian tubes. These can, during the development of the genital tract, intrauterine and in the childhood, there will be a cyst related to the fallopian tube, but it is not related to the ovary. So it is called para-ovarian, which is like attached to the fallopian tube, but it is not the ovary. It is not related at all to polycystic ovary, and it is not affecting the fertility at all. But when it is big cyst, then it should be removed. It can happen accident in this cyst specifically. It can happen infection. It can happen rupture of the cyst, hemorrhage inside the cyst. So it should be removed when it is a certain size. But para-ovarian cyst, whether it is related to polycystic ovary, no, it is not related. This is another pathology, which is not ovarian cyst, and it cannot affect the fertility.
Thank you so much. And Dr. JC, Elizabeth has a great question here. Is there an increased risk of postnatal depression in women with PCOS, and should they be screened in pregnancy?
Counseling matters because what I've seen is, yes, we see postnatal depression, yes, because now what happens is it is not, the family things have changed. You need a support system now. So now I see in my patients, due to the COVID changes now, it's become confined to the husband and wife alone. So I see my postnatal patients coming in with a lot of changes, but I screen them early, I speak to them, so that they open out, because in a culture like ours, we don't have counselors much. So it's not basically related to polycystic ovary, because it's basically related to everyone, I feel now, because of the changes around us, the surrounding, because you don't have help, you don't have family coming in. So this as such is a general change we see nowadays. So it's not just for polycystic. I think generally all our patients, when they come in for the postnatal checkup, I speak to them how they feel, and some of them open up to me, and then we could help them. So this is something that I'm seeing in the recent changes post-COVID.
Absolutely. I mean, having a newborn baby is one of the hardest times, and definitely one that will affect us more during COVID. Dr. Ahmed, please.
Sally, I might like to comment on this as well, because very important, we have postpartum hypothyroidism, which can cause this depression. So very important, if somebody have depression postpartum, to be really investigated for a thyroid dysfunction, and basically usually it is a hypothyroid.
That's a really important point, because for us, we're not aware of these things being related as well. Dr. Ala, sorry, did you want to add to that?
Sally, I want to say that's the good thing between us. We have the two different specialties together as the team. That's how it is.
Absolutely. That's why we bring you together. Dr. Ala.
Yeah, postpartum depression and maternity blue is a very important aspect that had been forgotten by many obstetricians and gynecologists. We usually concentrate on the physical part of the woman, whether she had a breastfeeding, her uterus is fine, her wound is fine, but most of the times we forgot this important issue. Postpartum depression is very common, and it can affect a wide range of community. And this is a mandatory screening when we have it for the postnatal visit, because women, they usually have it, not only in the COVID time. And in the COVID time, we might have it more, but before that, postpartum depression is a very important issue that should be screened for every woman.
Yes, I absolutely agree. And the thing about being a mother and becoming a mother, you have to be strong. and you have to be there for your newborn child and for your family. And, we forget that women need the support, and sometimes we don't want to come forward and say, I'm really struggling, because it looks like a weakness. So it's really important that we support women, we support new mothers, we support mothers to be able to open up and talk about that, and to get the support that they need. If you need the support, it doesn't mean that you are weak at all. You're still strong, but sometimes we all need that support. A final question that I can see, this one from Dr. Ebby, saying, I've had repeated cornual pregnancies and had to terminate with intracardiac KCL injections. Does PCOS have a role in causing this? Who would like to take that? Dr. JC.
Cornual pregnancies is a totally different entity, where it's a kind of an ectopic pregnancy. We call it as a cornual because the pregnancy, as we know, first happens in the tube, the fertilization, and it takes at least few days, like 5 days, for it to reach into the uterus. So this is something beyond polycystic. Polycystic is something where we deal with hormone release from the ovary. Because of the ovulation not happening correct, the woman fertilization is hindered. So here she's conceiving, but the problem is the location where it is happening is not right. So this is something quite different. The ideal approach for this, if she's had repeated cornual pregnancies, I don't know whether it's on the same side, whether she had it, then just having a single cornual pregnancy is still okay. But we advise the patient to evaluate her tubes after that to know whether there is anything to do with the tubal patency.
Thank you so much. And, fantastic questions for our audience as well. And this is it. We have actually received one more question, bringing it in just in the last minute. Okay. This one is asking about blocked tubes with PCOS. Can blocked tubes be a reason for PCOS? That is from Sonal. Dr. Ala, would you like to take that one?
Yeah. Yes, I can take this one. Fallopian tube is an organ, okay, and the ovary is an organ. The polycystic ovary disease is an entity. It is a disorder that it can affect the ovulation, so it can affect the fertility. Blockage of the tube is another disorder that it can affect the transfer of the fertilized ovum through the fallopian tube to the endometrium, to the cavity of the womb. So it is a different entity. It is not related to the polycystic ovary. If the woman had the two disorders together, she had blocked tube and polycystic ovary, then the treatment will be different completely from only polycystic ovary. And if she had only blocked tube and no polycystic ovary, then the treatment also is different. So it is completely different entity. Yes, it can affect definitely the fertility, depending whether it is one tube is blocked or two tube is blocked, and the cause of a tubal blockage.
Very important. And, this really emphasizes the point here that, as we come to the end of the webinar, we have our amazing doctors with us who have been able to answer the questions so well, but it doesn't replace a comprehensive consultation with your healthcare professional. So make sure you do book with any of these amazing doctors that we have had with us here today. Dr. JC Janker, Dr. Ala Yunus Muhammad, and Dr. Ahmed Hassoun. Amazing advice from all of you here today. You can consult with them and other world-class health experts at Fakeeh University Hospital. And the details for the hospital, as we did say, are available by clicking on the speakers and booths buttons at the top of the page. And of course, we want to say a big thank you to you, Dr. Ahmed, Dr. Ala, and Dr. JC. Thank you so much for sharing your amazing advice.
Thank you, Sally.
And a big thank you, of course, to you, our audience, for joining in the discussion today. And the session is going to be available online on the Gulf News and the AGNC3 YouTube channels. So don't forget, You can share them, you can subscribe, so you don't miss a thing. And this is a session that I know many more women will benefit from, so do share it far and wide. My name is Sally Musa, and I'm going to see you next time.
Thank you, Sally. Thank you.
Thank you.
Thank you, my team, Dr. Ala and Daisy. Thank you very much.
Thank you, Sally.